All right, let's dive right in. Today, we're stepping into one of the most high-stakes situations for any surgeon, the consultant oral exam, or viva. We are going to walk through a classic thyroid nodule case, showing you exactly how to break it down step by step to absolutely nail the answer. Let's get started.
So picture this. You're in the hot seat. You've spent years getting to this point. The room is dead silent, and across the table, two senior consultants are watching you. One of them leans in, looks you straight in the eye, and the exam begins.
And here it is, the opening scenario. This first question isn't just about facts. It's designed to see if you can think clearly under pressure and, most importantly, if you have a safe, structured way of thinking right from the very beginning. A 42-year-old female presents to the clinic complaining of a left neck mass for 3 months. How do you approach this patient? Okay, the clock's ticking. Your first move? The patient history. Look, the examiner wants more than just a list of questions. They're watching your process, your framework. A logical, step-by-step approach is the only way to score points and prove you're a safe pair of hands. Here's how you'd want to respond. Well, first, I'd introduce myself, make sure we have privacy, and get permission. Then, I'd work through a system. I'd start with the lump itself. When did it start? Has it changed? Then, I'd ask about pressure symptoms, things like voice changes or trouble swallowing. Next, I'd screen for any signs of thyroid dysfunction, both hyper and hypo. Crucially, I'd then dig into any specific risk factors for cancer before wrapping up with questions about general well-being and any symptoms of spread.
Good. Tell me, what specific risk factors for malignancy are you looking for?
I'm focused on 3 high-yield areas. Number 1, any family history of thyroid cancer. Number 2, a personal history of radiation therapy to the neck, especially during childhood. And number 3, any personal or family history of specific endocrine syndromes, like multiple endocrine neoplasia or M.
And that is a perfect transition. You see how a really solid history naturally sets up a focused physical exam? The candidate has basically built a roadmap of what to look for. Now the examiner gives them a little more to go on.
Okay. The patient confirms the mass is growing. She denies any other symptoms, and she has no risk factors for malignancy. What's next?
My next step is a comprehensive clinical examination. I'd start with a general look for any signs of an overactive thyroid, like a fine tremor or prominent eyes, and I'd check her vitals. Then, zeroing in on the neck, I'd watch the mass as she swallows and sticks out her tongue. The real heart of the exam, though, is palpation, feeling the windpipe, the lump itself, and carefully checking all the lymph node chains in the neck. I'd finish up by tapping on the breastbone to check for any extension into the chest, listening for a bruit, and doing a quick systemic check for any signs of spread. And that right there closed the loop on the clinical assessment. History and exam are done. Now we move into investigations. This is where you use hard data to start confirming or ruling out your suspicions and to build a solid plan. You've finished your examination. You find a firm, mobile, non-tender nodule in the left lobe of the thyroid. The rest of your exam is normal. What investigations are you going to order first? I would start with 2 key investigations. First, a simple blood test for thyroid function, the TFT, to see where her hormone levels are at. And second, probably most important at this stage, an ultrasound of the neck. This will let me really see the nodule's characteristics and check the rest of the gland and lymph nodes.
And on that ultrasound, what specific suspicious features would you be looking for in the radiologist's report?
I'd have a mental checklist of red flags for malignancy. I'm looking for a nodule that's dark or hypoechoic, a shape that's taller than it is wide, fuzzy or irregular margins, the presence of tiny flecks of calcium, what we call microcalcifications, a lot of blood flow inside the nodule itself, and finally, if it's missing that nice, clean halo around it. Excellent. The results are in. Her thyroid function test is completely normal. The ultrasound confirms a 3.2 centimeter solid nodule on the left side with heterogeneous features. What is your next step? For a solid nodule of this size in a patient with normal thyroid function, the next step is non-negotiable. We need a tissue diagnosis. I would arrange for an ultrasound-guided fine needle aspiration, or FNA, to get some cells for the lab. The FNA is done, the cytology report comes back, Bethesda IV, suspicious for follicular neoplasm. Okay, so what in the world does Bethesda IV mean? You can think of it as the we're not sure category. The cells look like they're from a follicular tumor, but just by looking at the cells from a needle, you can't tell if it's benign or cancerous.
To know for sure, you need to see the whole nodule under a microscope. This result means there's about a 15 to 30% chance it's cancer, and it pretty much always means surgery is needed to get the final answer. This result is a huge turning point in the viva. The diagnosis is now officially uncertain, and the candidate has to create a safe, logical plan that balances the need for a diagnosis with the risks of surgery. This is where you really start to demonstrate consultant-level thinking. So, with this Bethesda IV result in hand, lay out your management plan for this patient. My plan starts with talking to the patient. I'd explain what the result means, that it's inconclusive, and that we need surgery to get a final answer. The operation I'd propose is a diagnostic left thyroid lobectomy. Before surgery, I'd want a baseline check of her vocal cords. Then we'd get her ready with a standard prep like fasting and DVT prevention. And of course, I would have a detailed discussion to get her informed consent, making sure she fully understands the key risks. You mentioned consent. For this specific operation, what are the most important complications you would discuss with her? When consenting, I would focus on the big ones. First, nerve injury. I'd explain that damage to a smaller nerve could affect her ability to project her voice, while injury to the main nerve could cause significant hoarseness. Second is bleeding into the neck after the operation, which is rare but can be an emergency. Third is the risk of low calcium if the nearby parathyroid glands get stunned, which can cause tingling or muscle cramps. And I have to jump in here with a massive red flag for any exam. A one-sided nerve injury is a big deal, but a two-sided injury is a life-threatening surgical emergency. It can cause the vocal cords to close off the airway, requiring an immediate tracheostomy. It's an absolute never event that you have to know how to avoid, and if it happens, how to manage it instantly. You go ahead with the left lobectomy. The surgery is uneventful, and she recovers well. A few days later, the final pathology report on the whole specimen comes back. It shows a 3-centimeter follicular variant of papillary thyroid cancer. The margins are clear. You would, of course, discuss this result in your multidisciplinary team meeting. What is your definitive management plan now? The definitive management would be a completion thyroidectomy. For a 3-centimeter papillary cancer, this is standard of care. There are a few reasons. It removes any tiny bits of cancer that might be in the other lobe. It makes it much easier to monitor for recurrence down the line using a blood test. And, most importantly, you need to remove all the thyroid tissue if the patient needs radioactive iodine therapy, which is a key treatment for tumors this size to lower the risk of it ever coming back. And that brings our viva to a successful close. You see how what starts as a simple neck lump unfolds into a complex exercise in surgical judgment. It's this constant balancing act, weighing the what-ifs against the very real risks of surgery. This case just perfectly captures that challenge at the heart of what surgeons do every day. And it's a skill that truly defines the art of this profession.